mouthful of. If it is more than one mouthful of, it means it is more than 40 milligram per kg. Okay. So it will result in death from the 5th day to several weeks. So it is not that first 2 days patient is survived. So the patient will survive. It is not that. When it is less than 20 milligram, they will have some kind of GI symptoms and then they will slowly improve. Okay. How it acts? It is mainly acting on the redox cyclic. As I already told you, it is about a mitochondrial toxicity. So this paraquat will go and react with the molecular oxygen. It will release the superoxide radical. So under NADPH, this will go and cause a cellular injury and then cellular death. Especially more predominantly it is seen in the lungs. Okay. So the redox reaction, what really happens is the redox reaction has a two phase. One is initial phase, another one is later phase. Initial phase, it is a destructive phase where there will be loss of alveolar cells will be there in the lung and there produces a inflammatory reaction. It is actually reversible. If you give immunosuppression and putting the patient on a prolonged proning and then continue with the spirometry and other stuff, they will be reversible. Whereas proliferative phase, it will go for a fibrosis of the intestine. Okay, once the fibrosis of the intestine is there, then it produces the fibrosis of the alveolar space. So what really happens is it causes not only acute respiratory failure, it involves all the system. Okay, all the system will be included. Multi-system failure can occur. So this multi-failure system initially starts with the GI. So the gut failure is the first and foremost problem occurs in this group of patients. So this will produces GIT corrosion, okay, and then this will slowly go for perforation and causes hemorrhage. Whereas then after the GI involvement, it start attacking the liver. It goes for a hepatocellular necrosis and hepatocellular failure. The patient will develop stress, jaundice will be there, the bilirubin will be very high, and then slowly patient will go for hepatic encephalopathy. And at the same time, the patient will go for acute tubular necrosis and renal failure. This condition worsens. So this will go for a congestive heart failure and pulmonary edema. And some patients will develop pneumothorax, ARDS, and pulmonary fibrosis. Okay. So the skin and mucosal exposure, when it then occurs, most of the people, just to cheat the people, they will say that I have drank and they will just pour in their face and other things. They will cause local irritation either in the skin or in the eye or in the mucosa. The ulceration of epithelial surface and bleeding, and it also produces severe mouth ulcers. Okay, severe mouth ulcers will be there. Most of the time, the patient presence is actually in asymptomatic. Then it will develop into breathlessness, toxic myocarditis, going for pulmonary edema, ARDS, acute liver failure, then proceeding to acute kidney failure. They will go for MODS and then death will occur. Okay, these patients course will be like this. So if you intervene this patient or the dose is very less, then this patient having some kind of oral or GI ulcer, they can survive. Symptomatically, few patients, they will develop oral and GI ulcer, delayed pulmonary fibrosis will occur, and then the patient will die. Okay, so this very, very important is this paraquat is always will come in a plastic container. Sometimes the patient will come and tell you, I have mixed this in a glass container and then I have drank this, then when it is safe, because this goes and binds to the glass and then this will not have an active compound. So this is one of the important clue. Few paraquat poisons will be able to survive. Okay. So what are the investigation you need to do? You need to do a chest X-ray, ECG, pulmonary liver function test, renal test you have to do, and you can do for a plasma paraquat level. but it is very, very difficult for us to do the serum level. What we can do is bedside, it's to just easy to do this. What we can do is you can take a urine and 5 ml of urine can be added with 5 milligram of HCO3 plus 5 milligram of diethylene. This is called as diethylene test. It is a bedside test.
मुझे ऐसा ही लग रहा है
So this will produce us a very intense. This will produce an intense blue-green level. It is to be positive, and slowly this will change. Okay. What are the pre-hospital? Excuse me, please mute. I'm not able to continue. Please mute yourself. So in a pre-hospital care, if you came to know that the patient is taken Paraquat, so what you can do is you can start early charcoal or you can use Multani Matti. Multani Matti is considered to be better than the activated charcoal. Okay, this will start binding with the Paraquat. If nothing is there, you can ask them to take a clay. Okay, just because the Paraquat will bind with the clay and it will not produce any toxicity. Even if they have taken 100 ml, ask them to take immediate clay. Okay, this will reduce the incidence of mortality. Okay, then you can do a early gentle decontamination done. In hospital, what you can do is you start with the early charcoal, decontamination is over, then you can start them on either charcoal hemoperfusion. Please unmute yourself. I'm not able Excuse me. Please unmute yourself. Mute yourself. So initially it was advised to do for a plasmapheresis, but now the plasmapheresis results are not good. So it is always advised to go for a charcoal hemoperfusion or resin dialysis. Okay. Then you can start with the immunosuppression with the corticosteroid cyclophosphamide. Okay. Corticosteroid is 15 milligram per kg, maximum 1 gram can be given. This has to be given only for 3 days. If you continue for further more days, this will go for a severe bone marrow depression and then the patient will die because of sepsis. Okay. Secondary sepsis is very, very worsen to kill the patient of Paraquat. Airway protection is very, very important. But one important thing is you should not give oxygen for this patient. So once you give oxygen, this will increase the redox cycle and more amount of superoxide will be generated and produces more harm. Okay. So you can use local anesthetic spray or a mouthwash. Okay. Then you can start. Intubating, putting the patient on a ventilator is a palliative care. Very soon they will die. Okay. So now we are moving into another important thing is called endosulfone. Now it is almost banned. It is very difficult to see, but still a lot of people are coming. For last year, we had treated almost 60 patients, comparatively very, very low, but still there is a chance that you may come across. So this is a patient poison will present always with the status epilepticus and it will be very, very refractory. Okay. So endosulfone poison is nothing but chlorinated, okay, chlorinated insecticide. This will absorb through the skin, inhalation, oral, just by spraying also this will produces. This is mainly used to spray on the cotton field, okay. So what really happens is this will go and alter the electrophysiological level activity in the nerve cell membrane. So when there is a disturbance in the calcium channel port, so the calcium ATPase activity will be totally disturbed. So it will be changed into the kinetics of sodium potassium ATPase through the membrane. So once this membrane is activated, this goes and antagonizes the GABA channel. So once the GABA is antagonized, uncontrolled excitation will be there and produces sudden seizure. Okay. So you will see the sudden onset of refractory convulsions will be there. Patient will be in comatose, respiratory depression, rhabdomyolysis, renal failure, arrhythmias, and electrolytic abnormalities will be happening. So managing this case is very, very important. The patient has to be intubated early, has to be paralyzed, continuous thing has to be there, because this patient, the mortality is very, very high. When I started my practice in 2000, we used to see a lot of patients with endosulfan. They will come on the second day, they will die. So initially we didn't know how to manage this patient. Then later we sat, we analyzed the case, a lot of mortality meeting, we had a discussion. Then we formulated a protocol. Slowly we improvised the protocol, and since then we have saved more than 400 patients of endosulfan. Okay, with this our protocol, and no death was being reported after that. So then slowly it was banned by the government. So now it is not freely available, but still the old endosulfans are coming, and they are also equally toxic. Okay, they die because of severe cerebral edema and coning. Rhabdomyolysis, renal failure will be there. Hypotension will be there, secondary to toxic myocarditis or anticonvulsant overdose. Okay, so always you have to do a elective intubation and ventilation has to be done. So large bore IV access has to be taken or central access, and start early vasopressors. And we know that status epilepticus protocol, here you have to start lorazepam full dose, then phenobarbital has to be given within 30 minutes, even before the convulsion. If convulsion started appearing, it will be very refractive, will not respond to anything. Yeah, so you have to start with the thiopentone, or you can start with the propofol. Okay, in the dose of 250 milligram per hour as a bolus, and then diluted in the 10 ml saline until the seizures stops. Then you can continue the infusion 5 milligram per kg body weight. Okay. So to stop the convulsion, we know that in case of eclampsia, we use magnesium sulfate as a membrane stabilization. When it is refractory, we paralyze the patient, start on midazolam infusion. Same we did. Gastric lavage was being done after intubation and protected. So here the cerebral edema is very, very important, deadly combination. So we start mannitol 150 ml 8th hourly and start with the steroids. Okay, head up, minimal peak. And don't disturb anything, just like treating a tetanus patient, and you have to have it in a thing and put them on a barbiturate coma. Very important this, whenever the patient is started on barbiturate, the patient will looks like a brain death. Don't pronounce brain death without estimating the doing EEG or doing a DSA to know the flow of the brain. Okay, so this is a protocol we designed in a Vinayaka mission. It is called as Vinayaka protocol for endosulfan poisoning. What I told, we did the same. Now the important aluminum and zinc phosphate. Okay, the aluminum phosphate comes as a cell pass. It is grayish white tablet, 3 gram each. It comes in a garlic odor. Okay, and it carries very high mortality. And another thing is now the Ratol is being banned, but still it is freely available. It is called Ratil. It is a zinc phosphate. Both behaves similarly one. So we don't know how to do that, because most of the time they will say that it is rodenticide poisoning we have taken, like that they used to say. So the patient is asked to breathe for 5 to 10 minutes in a filter paper, which is impregnated with a silver nitrate. The paper will turn black. It will give a clue that the patient is taken aluminum phosphate or zinc phosphate, whatever may be. Okay, but important thing, you should not stand in front of the patient when the patient is blowing the breath. Okay, this will get contaminated with you, and you can get a phosphine toxicity. So always give the paper and move away from them as to breathe. Okay, so what is the problem here? It releases the phosphine. Again, it is a mitochondrial toxicity. It goes and affects the cytochrome P450 at the mitochondrial level so that it produces severe toxic myocarditis, systemic acidosis, which is not even responding to your continuous bicarbonate infusion, goes for a distributive cardio and cardiogenic shock, acute kidney injury, multi-organ failure and death can be there. So important thing is in aluminum phosphate in a pre-hospital care, you should not do a water lavage. Even you should not give water to induce vomiting. Okay. If any known patients or of you have taken aluminum phosphate, immediately ask them to drink coconut oil. Okay. So that will help you out to come out. And toxic myocarditis or distributive shock, what we can do is we can start them on high dose of noradrenaline, dopamine, and put them on a JIC infusion, then ECMO. ECMO is the magic here. So if you put ECMO, then the patient will improve. Or if your patient is taken only a small quantity and acidosis only there is no toxic myocarditis, then you can start them on CRRT. Continuous CRRT will help them to go. Okay. Charcoal hemoperfusion can be tried, but CRRT works very well. And other complications of charcoal hemoperfusion like thrombocytopenia, bleeding manifestations will not be happen in CRRT. Okay. And then you can start them on bicarbonate infusion. This is Ratol, as everybody knows. It is a 3% yellow phosphorus. Okay, it mimics like a paracetamol overdose. So initially they will be asymptomatic for first 3 days. Then slowly they will develop all toxic hepatitis, necrosis, kidney failure. So the death occurs within 7 to 10 days. So it is N-acetylcysteine. You have to give them, and it can be extended up to 5 days. If toxic hepatitis is worsening, you can start them on blood transfusion, but I don't advise you unless you do a plasmapheresis. Don't do FFB transplant and plan for early liver transplant. And this is very, very common. I don't know how much it is common in your area. Supravasomal poisoning or hair dye. Okay, it produces severe laryngeal edema. Patient will come with a stridor. Rhabdomyolysis will be there. So early tracheostomy has to be there. And doing intubation is very, very difficult. So better call your ENT colleague to do a tracheostomy as early as possible. So hydrate the patient, alkalize the urine. If not responding, then you can start them on acute kidney injury. And this is about methemoglobinemia. Okay, very common in our area, especially in the February, March, April, the flowering season. For the mango fruits, they used to spray this nitrate containing compound. So it is called as a saturation gap. So the ABG will show you high amount of oxygenation. Here PaO2 is 250, whereas in the pulse oximeter it shows only 78. Okay. So this flowering agent is very worse. Many times they think that it is a organophosphate. They give atropine and then patient goes for a delirium and then they later shift to us for further management. Okay. So always suspect methemoglobinemia whenever you see a saturation gap, cyanosis, or the patient is having a central oxygen cyanosis which is not improving. We can also do a filter paper test. By doing filter paper test, you can be able to identify the chocolate brown color, and then you can estimate this. Okay, these are the various other compounds starting from benzocaine to nitroglycerin. Anything can cause methemoglobinemia. You need to be very cautious, aware to treat. The antidote is methylene blue. It is 1 to 2 milligram per kg body weight. You have to infuse. Okay, and then maximum of 7 milligram per kg can be given. Still, it is not working. You can do a HN transfusion. You can support with ascorbic acid and dextrose infusion. This is very known only to Erode, Coimbatore, and Salem area. Okay, Congo belt. It is called as sani powder. That is a synthetic cow dung powder poisoning. It contained in 2 colors. One is yellow. It contains Oramingo. Green. It contains malachite green. Okay, so these are the 2 important compounds. They comes with a yellowish coloration can be seen. Both your conjunctiva, everything will be discolored. Body fluids will be discolored. Okay, either it is a green or it is yellow. You can see green produces seizure, whereas yellow produces toxic acute kidney injury. So green produces encephalopathy and hepatitis. Same yellow produces hepatitis, toxic hepatitis and renal acute kidney injury. So worst case, they will produce toxic myocarditis, shock and arrhythmia can occur. So various other complications we have seen like cramps, spasm, convulsion can also occur. Okay. So here, if the patient throws convulsion, you do a start amount lorazepam, phenobarbital can be given, and inotropic support like dopamine can be started to maintain the rate as well as the pressure. Okay. And never give phenytoin. Okay. Phenytoin or fosphenytoin should not be given in the seizure induced by the poison. Okay. In case of certain companies, they comes with arsenic. If it is an arsenic or heavy metal, then we can go for ball. Depencylamine can be continued. So you have to look for it. So don't directly jump that all synthetic powders are only Aramingo. Okay. So oleander seed, it is very common plant poisoning, occurs across country. There is not specific to any region. Okay, it mainly what really happens is this oleander. Okay, this goes and blocks your sodium potassium ATPase. So once sodium potassium ATPase is blocked, the potassium will be in the outside and sodium will be intracellularly. So this calcium will take over the way and lot of calcium will be secreted through the cell. So the sarcoplasmic reticulum will get affected by the mitochondrial thing and it produces a stony heart, okay, contraction. So this is called a stony heart. So very important in hyperkalemia induced by digoxin or by oleander, you should not give calcium gluconate. Okay, so these patients can have toxic myocarditis, hyperkalemia, tachyarrhythmia, bradyarrhythmia can be there. So important, you take care of airway breathing circulation, decontamination. If case of tachybrady, brady is also okay. Tachycardia is so more harm, and you can treat hyperkalemia. Or if the patient is affordable and it is there, then you can think of Digifab. But I have a very limited experience. Only 2 patients I have treated with the Digifab, but very good results can be obtained. In case of bradycardia, you can give atropine, you can start on isoprenaline, go for transcutaneous spacing. By personal experience, if you put transvenous spacing, lot of arrhythmias are there, malignant arrhythmia, it will be very difficult to save the patient. So it is always advised to go for a transcutaneous spacing. Okay. Tachyarrhythmias, you can follow ACLS algorithm like lidocaine, magnesium sulfate, and cardioversion can be your last resort. Digoxin Fab antibody therapy can be given. This is only for theoretical purpose. Just know that it is very difficult. For a single case, it will cost around 17 lakhs. Okay, because it is imported duty tax and all. If it is India, it comes around 7 lakhs. Okay, we have treated 2 patients. One is a medical college student where he has taken somewhere around 500 tablets of digoxin where we got for Digifab and we treated. Another one is another one VIP have taken some digoxin, oleander, Oduvantalai and then OPC. So multi dose poison was there at the time we used Digifab. So hyperkalemia, no calcium gluconate, other things can be used. So Clisanthes cholinus is again a slow cardiac poisoning. Remember that this produces severe hypokalemia. Toxic myocarditis will be there and ARDS. Once ARDS is settled, it is very difficult to save the patient. Okay. So early management within 6 hours, no death. Then you can correct them with multi-dose activated charcoal, other things, and then you can do a magnesium sulfate. Delayed management, definitely this patient will go for toxic myocarditis, non-cardiogenic pulmonary edema, or ARDS will be there, toxic myocarditis, all nonsense will occur, and you have to manage this patient, and it is very difficult to ventilate this patient. Okay. So never hold the intubation in a patient with distress. Even if it is a paraquat, intubate and then do a palliative care. You can do the multi-dose activated charcoal and start doing metoclopramide decreases the time of transit time. Okay, supportive care is the most important measures in a serious overdose. Okay, when in doubt, always observe the patient in ED. Still, you are facing any unfamiliar cases, always call the expert and get the opinion to avoid all medical legal cases, issues. Thank you. Any doubts? I'm happy to answer. Any doubts? No doubt? Thank you. Good night.